All right, guys, so tonight we're going to go over LVADs, and LVADs are becoming a lot more popular, and they're going to become a lot more popular very soon, and especially for us here in Lubbock, and we'll explain all that. So for continuing education hours, this equals 1 hour for medical for the state, or airway breathing and cardiology for National Registry. So some of the objectives tonight, we want to learn about the latest information with the LVADs that's coming out. We want to examine several LVADs of the models that are out and available today that you may be seeing here in the EMS world. We want to assess, treat, and learn of what to avoid with our LVAD patients. We want to gain an understanding of the more common controller alarms and kind of how to troubleshoot it. And they've really made this a lot easier for us with the new product that's coming out. And then we're going to review some EMS reports involved with LVADs. So why is this becoming important to us is because this month UMC is becoming an LVAD center. So what this is saying is we are going to be having a larger population of LVADs put in right here at our hospital at UMC. So you're going to be seeing these more frequently. Now maybe after they go to a step down, maybe across the street at the, not the Ronald McDonald House, but what's the other one right there? The Hope Lodge. So they may be going there as a step down type unit. And then, so we may be transferring them from there back to the hospital if we get into some problems. So, or they may be going home to their communities or back into Lubbock. And so we're going to talk about some of the numbers. Dr. Nair is the new cardiologist that is a congestive heart failure specialist, and Dr. Ben Hurst is going to be the surgeon with Dr. Paoni backing them up, placing the LVADs in right here in Lubbock. So as you can see on the UMC website, this has already popped up now. It says Ventricular Assist Services, and on Thoratech's website now, it now says University Medical Center as a LVAD center for the United States of America. So in saying that, which device will we be putting in here? Well, this is the brand new HeartMate 3. It is finishing up FDA approval and trialing. This is what device they'll be going to. But for the current, they're going to stay with the HeartMate 2, which is what all of you are familiar with now. So we're going to mainly stay tonight with talking about the HeartMate 2 for right now, since that is typically what we're going to be seeing. So first of all, let's talk about what is an LVAD. Well, under normal conditions, a healthy heart, the left ventricle pumps out and provides pressure, our cerebral pressure, coronary pressure, provides everything that the heart and the body needs to stay alive. Well, over decades of high blood pressure, viral infections, myocardial infarctions, these walls begin to weaken, or they may even get thick with congestive failure. And what this does is this moves us into a left-sided failure to where I cannot provide coronary cerebral pressure and body pressure, blood pressure out to the body. So this new device is meant to go in and is to act as an internal pump which takes over all or most of the left ventricle mechanical workings. And so we're going to break it down even further as we go into exactly how it works. So a little history on LVADs. From the 1970s and 80s, they've been trying to build an artificial heart. They've been trying this for many years without success. And then starting in the late 90s, they really started perfecting this. The 2000s, it got really hot and heavy. And about 2010, HeartMate perfected the HeartMate 2 series in 2010. And that's kind of 2010 is that remarkable year, okay? What year are we in now? 2016. We're not that far into this that we've really started perfecting this device. Now they've got several people on HeartMate devices that are in 17 years, I believe is the longest one. It's only meant to go 10, and this patient's 7 years past that now and still kicking and still doing well. So they really don't know the full term limits on this thing. So they're still kind of in the exploratory stage of that. But as far as what this device is used for, we're going to talk how successful this device is. Currently, we're in the second generation of these devices. Basically, guys, there's a lot of different devices on the market right now. There's about 5 prominent devices with about 80% of them using the HeartMate device across the nation. Now you may see some other kinds, and we do have some other kinds in New Mexico which may affect us, because with us being a HeartMate or a heart center, they may be coming into here, so you may see these. That's why I'm going to educate you on all of them. But basically, they all have the same. They're titanium, a stainless steel pump that's lubricated with, that's made with a special tubing that's supposed to prevent clotting from happening. This device ties into the bottom half. All of these different devices tie into the bottom half of the left ventricle, come through the pump, and then into the aorta. All of them have a controller or a brain. All of them have batteries. All of them have external plugs that they can plug into. And all the systems have both visual and audio alarms. And that's going to be a great thing for us because the new controllers that are out, it's really monkey-proof for us. Let me say that. It is very simple to work on these devices now because they've changed it to where it pretty much answers its own questions. Even our resident nurse could probably work on. That's just a joke. I had to say it. She's looking at me, so I had to poke on her. So how did this become famous? Well, this famous man right here in 2010, right after HeartMate got approved, Dick Cheney, the man of many heart attacks, the man of a very sick heart, now got a bridge device for transplant, and 20 months later, he got a new heart out of this deal. So he was not one of the first recipients, but he was one of the most famous recipient, and that really made it famous across the United States of seeing what happens with these devices. So these devices are typically a bridge device, and when I say a bridge device, is what I'm doing is I'm providing life by assisting the left ventricle, by pumping the left ventricle, becoming the left ventricle into the aorta until we can get a heart transplant. Some of these become destination devices, and when I say the term destination device, is they have several patients that are well in their 70s that are comfortable with their device, comfortable with their living habits, and they say, no, you use that heart and go give it to somebody younger than me. I'm comfortable where I'm at, and they're going to ride this device out till they pass. Others devices may even be a bridge device to healing. So they have a record of one female that went into heart failure postpartum, and she was 39 years old when she had her first baby. She went into heart failure. They were able to place this device, and 9 months later, she was able to transfer back out, sew the back heart up, hook all the electricity back up, and then we started pumping again. So she was able to allow her heart time to heal. So sometimes these bridge devices can mean a lot of different things for us. So the devices you're most likely to encounter, first of all, is the HeartMate 2 right now, and soon to be the HeartMate 3. There's also a HeartWare VAS, there's a Jarvik device, and the DuraHeart. Now, the DuraHeart got bought out lately by HeartMate, and so therefore they are in the process of phasing the DuraHeart out right now, but we still want to talk about it. All of these are very specialized therapies. Once again, there's only 150 hospitals across the United States that are implanting LVADs. Well, now there's 151 as of this month, UMC becoming that one. But as you can see, right now, most of our feeder hospitals are the Dallas area, Austin, Houston, and San Antonio. And then we also have a center in Albuquerque, And so now with UMC coming on board, that's going to put us kind of filling this large gap that's in the middle, in between up into some of Oklahoma and getting a lot of Texas. So as we currently stand, we have 7 LVADs inside the city limits of Lubbock. We got a new one about 3 or 4 weeks ago, which they did not notify us about. We found out when we arrived on scene. But as you can see, that these patients are going out back to your communities. So it may not just be in Lubbock, but it may be going to Post, it may be going to Plainview, it may be going to different places across West Texas. And sometimes, guys, these services may call and say, hey, meet us on the highway because we're not sure with what we got. And I have done some talks for the SPIMS region. Hopefully they'll harness that and maybe even use this CE, and they're welcome to that. So there's been a growing increase in LVADs. In 2013, they placed 25,000 LVADs in just 1 year inside the United States, compared to in 2007 when they first were trialing 338. So you can see these numbers are exponentially growing each year. So some of the survival rates with the second and third year devices 81% of the people are making it to transplant. 81% of the people are making it to transplant. That's an astronomical number. If I was to give you $100 and tell you go gamble in Vegas and 81% of the time you're going to win, what are you going to do? I'm going to play those odds all day. So these people are doing very well. For those that don't get a heart in the first year, the second year, about 70% of those patients are making it to transplant the second year. So very, very impressive numbers with especially as young as this program's going. So what is this meant for? This is meant for, as we break down by the New York Heart Association function classification of heart failure, they break it down off of class 1, which is no limitations of physical activity, and you do pretty good with heart failure. You do have some shortness of breath, some fatigue, and some palpitations. Level 2, this becomes a slight limitation in some physical activity, but you're comfortable at rest and you can kind of tolerate, but you still get tired and palpitations and some respiratory problems. At the level 3, this is where they start considering LVAD, and that's part of the goal is to start an LVAD earlier to where we're at the point where we have some marked limitations in our physical activity, but we're still fairly comfortable. Versus once I get here, this is where I'm unable to carry out any physical activity without discomfort. Why let them get that long? Because if they get into left-sided failure, the chances of you becoming right-sided failure are high. So that's part of the goal with UMC, and Dr. Nair has done, from what I understand, has done a very, very nice job at her previous. She's coming from Scott and White and Temple, being very aggressive with moving these folks from right here and giving them a chance before they get all the way down. So over 20,000 people have already had the implanted HeartMate 2 devices, which is great, astronomical numbers compared, but let's compare it. So 600,000 people in the US each year is diagnosed with class 4 heart failure. The sad thing is there's only 2,200 heart transplants available a year. That's all the donors that are available. So you can see the numbers are offset, and I'm still kind of curious how they're getting that 81% are making it to transplant. Those are usually the sickest of the sick that are going first. But you can see there's not a lot of heart donations. And so therefore, that's why it's becoming harder and harder to do these devices. I would also like to point out, after 20,000, you're getting 20,000 implanted out of 600. So some of these are still manageable with medicines. You may see Millerone drips, constant inotropium drips at home, which they'll be on. We have several patients in Lubbock that are on inotropium continuously right now. Those patients will transition to a HeartMate probably fairly soon with us having a center here. So how do we know that the patient has an LVAD? Well, first of all, they're going to hopefully tell us as soon as we walk in the door. Hopefully it's going to be in our MDT. We've got a program together trying to identify these things to where I can mark them to where we can start making sure that you have plenty of help, and we'll talk about what help we need here in just a little bit. But as we get there, they're going to have a battery pack, which are going to be mobile for hours. They may have a vest. They may have an extra bag with them that's their go bag. Typically on the controller, they've got their fanny pack. And you can see this guy's been out fishing. He's got his controller right here, and he's got his gun vest on both sides, which is his battery pack. And so that's kind of, you can see how this system, well, we're going to break this system down, but this is what they'll look like as a whole. So typical components of the LVAD, the very important parts, first of all, is the system controller, or the brains of the operation, which usually sits externally outside the body, and it usually sits at the waist area. Then they have their battery packs, or they're hooked up to the power module at home. And then there's 3 cables that are coming out of the controller, 1 going into the patient and then 2 going to the batteries. And we'll break this down as we get closer to that. So let's start talking about the actual pump and all. So this is what the patient's abdomen, this is a view right side, just the right side of the umbilici. This is the #1 problem that they have with LVADs is infection with this area right here. This is the percutaneous cord coming out, or the percutaneous lead, or they call it a drive line. So this is coming out of the right side of the umbilici right there. You can tell a lot of times if, it's just like a Mickey button or a peg tube, if they get pulled, they'll get irritated, they can get infected. This is the #1 cause of having to go to the hospital, is infection from this area. The important part is this internal pump sits just inside of the chest cavity on the left-hand side at about the 6th intercostal space at the apex of the heart. You should hear a whirling noise right there, or a low hum noise. And so that's going to be very important to us later on when we talk about how we're going to assess these patients. The controller, once again, you can tell this is a female's hand. It's not very big, very small controller nowadays. And this is one of the brand new controllers that is very simple to use. As you can see, everything's color coded with how it goes in and locks. This is once again the pocket controller. It has audible and visual alarms to it. And the caregivers are usually very fully educated, so part of it is after they get done with their healing portion of it, the family basically moves into the hospital with them and teaches them the complete ins and outs of how to take care of this thing, how to change the batteries out, what order it's got to go in. So just like our pediatric population, our family is crucially important to us. It is so important to us that this is the only time we allow for Code 3 transport with a family in the back of the unit. And so I need to strap them in. I need to make sure they're safe and they're secure first and foremost. But guys, you've got to have the family there, because if this goes bad, you've got to have them to put everything back together. You can probably pretty much figure it out, but this is one of those we don't want to be pretty much figuring it out on. We want to be absolutely for sure we get everything connected in the right way. So the system controller, once again, comes right out of the percutaneous. Now this is the actual device here, the percutaneous, which is internal the body. Then it comes out right on the other side of the abdomen, right at the right side of the umbilici. And this is the percutaneous cord that I'm talking about. This turns right into the controller. Now this is actually an older controller right here that we have a picture of. But both of these cables have to be plugged in certain ways, and they twist and they lock, and they have to be set just perfect. One of the biggest things is we want to make sure that we only change our batteries out one at a time. That way we have constant power to the device at any time. If they lose power to this device, it can be fatal for them, and we'll visit more about that. This is the look at the brand new controller that's out on the market. As you can see, it says disconnected drive line. If that drive line is disconnected, therefore the pump is not running, this would be the most fatal thing that you could possibly find at one time with an LVAD. This is something very easy to fix, but could be fatal to them. But do we want to restart it? That's the big question at that point, because when blood stops, it becomes what? Stagnant. And when it's stagnant, it makes clots and boogers. And when we turn it back on and we start throwing clots and boogers, we get into the world of hurt with stroke, pulmonary embolism, cardiac embolism. We can cause a lot of problems downhill for that. The messaging in the center is very intuitive. It's very clear to read and very easy to understand, as everything will be popping up right here on this. The nice thing is there's an LVAD coordinator. UMC does have an LVAD coordinator. I'll be getting that information on all the trucks in the next month. The LVAD coordinator is available 24 hours a day, 7 days a week, 365 days a year. So it's very easy to get a hold of them. It's one phone call, and they'll answer the phone and be able to answer any questions that you have. Now, if you sometimes might be trying to get a hold of your chief in the middle of the night, it may take them a while to get their senses about themselves of what's going on. And no different with the coordinator. They're going to have to wake up if it's at night and kind of get it going. No comments, Hal?
No.
Okay, the power source. So these are the external lithium batteries. Nowadays they have a charge of 10 to 12 hours as a set, and they run simultaneously. They draw equally at the same time, and you have about 10 to 12 hours with that. So these people can be mobile. They can go shopping, they can go fishing, they can take trips, and they can go places. And so this allows them to really be mobile. The older batteries had a battery last of about 3 to 4 hours. And so they were very limited with how far they could go, but they've really extended the battery life right now. A lot of these patients return back to work, so you may pick them up from their offices, so they're able to continue on with their life. The module power, or the power that they have at home, this is on about a 20 to 25 foot cord. It is a little bit bulky, but it sits right beside the patient. It plugs into where their batteries would go, and it provides them energy and power through the night, so they don't have to worry about getting up to change batteries out. The nice thing is it can be switched over to a 12 volt. So if we are having a battery problem, we can plug into our trucks. Actually, we don't have.
Not on the new ones, they don't have inverters.
But do they have a cigarette lighter in the back? So you can plug into the 12 volt in the back at all times, and so you're always going to have power by your module. Okay. Now the older trucks, the 98 and 99 that we have, still have inverters on them, so you could plug into the back of that, or you can switch over to DC power, not a problem. The alarm will sound if the batteries start to get low. It'll give you a certain amount of warning. And so you're going to be able to know, I've got to switch batteries, I've got to, I may have to get them over to module power, and I need to do that fairly quickly. The cables. The cables are a big part. Everything is color coded. It's either black or it's white. That tells you exactly. It'll only fit to certain ways. There'll be a half moon shape, and it'll only be one battery will fit one way, the other battery will fit the other way. The percutaneous, or the drive line cable that goes to the percutaneous cord, plugs in a certain way. They called this the death button, the dead red button, isn't that what they called it? And so this actually has a cover. In order for you to disconnect the drive line, you have to actually physically remove this slide right here and push the button in and then unhook it. There's very, very, very few situations. The only situation is if the controller goes dead and does not work, and you know your batteries are good, then you may have to change the drive line out, which you've got to do that very, very quickly, because once you unplug, that device stops inside their chest, once again causing stagnant blood and clots and boogers, and that can create us a problem. We want to make sure that we do not set a heavy monitor or anything else on our patients. Keep trauma shears away from these. They're going to be very protective of this, especially the percutaneous cord coming out of their stomach, because that is their lifeline, and they understand that they have to have this device. Most of these plugs, once again, are very easy to plug in and twist. They'll lock in. They're very easy to put in and out. So what kinds do we have here? First and foremost, all of our patients in Lubbock are currently being treated with a HeartMate 2. Dallas, Houston, Austin, San Antonio, and Galveston are all placing the HeartMate 2. The heartware, we do not have any heartwares here in Lubbock currently, but Eastern New Mexico and Ruidoso have 2 Jarvik devices. They may be traveling through. They may have a car wreck here. They may slip and fall at the mall. You don't ever know, but they do have a couple of Jarvik in Eastern New Mexico that may end up here. And then once again, the Heart Assist 5 device. This is new and only available in Europe, but they're looking at bringing it into the U.S. So once again, it's not a lot of difference, but we want to just discuss what we have. So let's talk about the HeartMate 2. So this is our big boy right now. This is once again what we will be using here at UMC. It's 400 grams, and it has the ability of pumping 10 liters per minute through. So normal flow of the heart should be, how much? About 4 liters per minute is what the heart should pump. This has the ability to go up to 10 liters. It is a constant flow device, therefore there's no pulsating of the heart anymore. That's an important part, because now our patients are going to not have a pulse. As you can see, this is just a kind of a torpedo tube. It runs off of a magnet type system, and the blood comes in from the left ventricle, flows right through the device, and then up and out through the aorta. The heartware is, once again, it's a little bit lighter. It's 160 grams, a little bit smaller, more of a flat fit. This is what the HeartMate 3 is going to be looking a lot like. Once again, you'll probably never see the inside of this device. If you're seeing this device tied into the heart, we have a very serious problem. But once again, still has a percutaneous cord, has the controllers, the batteries. Some of the places in Austin, Houston, and San Antonio are using these. Phoenix and Tucson are using this as well. Therefore, guys, just because we have a heart center here doesn't mean people are always going to use it. They still may choose to go out and then come back into Lubbock. So there is a chance you could see one of these devices. But at the end of the day, it's the same. It draws blood in, it's going to pump it through and right out to the aorta. Next is the Heart Assist 5. It's even lighter. It's 92 grams. As you can see, it actually fits up into. The only thing about this device is it actually works with a pump. So you actually will have compressions. I'm sorry, you will have pulses with this that will be able to be palpable at some point. It is also wireless. This is something they're still trying to perfect and make sure that it's doing quite well, but it's all wireless, and that can be a huge benefit because the number one reason, once again, why the LVAD patients go to the hospital is infection of the percutaneous line. Do what?
They still have a line, it's wireless.
Well, they still have a line, but it's all wireless control from
They
that
send
point.
data to the data center.
Yeah, to the data center. So it's going to be a really, really neat device if they can get this really up and going. Last but not least is the Jarvik 2000. It's the smallest. It's only 90 grams. It may be a little bit more compatible for some of our smaller patients. They are planning on doing the HeartMate in some pediatric patients here if we have a pediatric failure patient. And so they can run this down to a little smaller. The only difference with this device is it actually has a audible jack that runs up the back and then runs into the back of the ear. Everything is controlled from back there instead of having a percutaneous wire. The only problem is the Jarvik device is custom made by Dr. Jarvik up in the Northeast, and so they're very, very hard. There's a waiting list for them, and it has to be a very special situation in order to get these. Like I said, Riadosa has 2 Jarvik devices right now. With us being a heart center, they may choose to come here. It's about an hour closer here than it is to go to Albuquerque. They may choose to come to our center. I don't know, but there is a chance you could be seeing this device just knowing that the Jarvik is controlled by the back of the ear instead of having a percutaneous wire. So don't be afraid of your LVAD patients. We need to assess them. We can give them fluids. We just want to make sure we're not dropping pressure. They're already anticoagulated, which we're going to talk about. And then the patient, and we can treat them for pain. And I'm going to break each one of these down so we kind of get a better understanding. So once again, these patients, there's a very strong chance they will have no pulse. This is normal for them. Remember, I've gone to a flow device instead of my left ventricle pulsating or contracting. And so these patients will typically not have a pulse. Well, if they don't have a pulse, I can't take a blood pressure. I can't take pulse oximetry. And so that limits with what I can do for them and how I can treat them. Most LVADs, once again, are a constant flow device. So pulse oximetry is going to be inaccurate at best, even if it even reads at all. And then the standard is using a Doppler device, a pencil Doppler, that they can use, and to get blood pulses or blood pressure from that, you'll pump it up, and we'll talk more about that if we may look into getting a couple of Dopplers and trying them out on some Foxtrots. We're going to have to just look into it a little bit further, but the Doppler is definitely the standard of care for receiving heart to check a full evaluation of the blood pressure of your LVAD patient. One of the things is if we start to see 10 more of these or 20 more of these, we may have to really start seriously looking into this, versus if we stay with just seeing 7 or 8, we can probably manage that a little bit easier. So we're just going to have to kind of look and see how the patient load is. Assessing the LVAD patient, once again, are they awake and are they answering my questions? That's a very simple thing. What's their color? Are they pink? Are they diaphoretic? Are they dry? You know, are they altered mental status? And so I've got to start using other means than having my blood pressure cuff and telling me exactly what it is. I need to look at my respirations. I need to first and foremost check my pump to make sure it's running. And so I'm going to need to auscultate over the 6th intercostal space on the left side, which should be about the apex of the left heart, and I should be able to hear that low roar sound. I should still be able to auscultate lung sounds. Yes, you're going to hear that roaring, but as I move, maybe use the back, I'm going to be able to hear my breath sounds. Don't forget your cardiac monitor. This becomes a very big spot. In our protocol, it specifically says all LVAD patients have to have end-tidal CO2. This tells us this is a number for us. It's a waveform. It's guaranteed that they're breathing, and it tells us what their lungs are doing. Are they compliant? Are they having bronchospasms? Are they not? Are they breathing? You know, are they trapping? Are they offloading their CO2? It's going to give us a lot of different things. Remember that the LVAD takes away the mechanical function of the left ventricle. It doesn't take away the electrical pathways that are still firing. So you're going to have an ECG. You'll have a P wave. You have QRS complexes. They should be narrow. You should have an ST segment because the right side of the heart is still firing very normal. So you should be able to see all these things. So really use our heart monitor. These patients can still go into VFib and VTAC and AFib with RVR and SVT. We can still have all the rhythms because the LVAD has only taken the mechanical function of the left heart. Once again, for obvious reasons, if they're the patient, do not treat PEA. All of them are in PEA. Okay, everybody agree with that. And if they're awake and alert and oriented, and you're looking at the monitor, yes, that's going to be PEA all day, but you know that the patient's alert. But if the patient becomes unresponsive and they show VFAB or VTAC or asystole in a couple of different leads, follow normal ACLS guidelines and treat them like we normally would, except for the compressions. As of current, we do compressions on these folks that are unresponsive in VFib or VTAC. That is changing. Dr. Nair does not want CPR done on these patients. This pump is able to draw enough flow and can have a continuous flow going through the heart even once you get it out of VFib or VTAC. Now, therefore, I have to treat the VFib and VTAC very quickly. But if the pump is running, so I'm going to have to listen first. If my patient's unresponsive, I'm going to have to listen to the pump, and if the pump is running, do not start compressions. If the pump is not running, however, you will have to start compressions because if you do nothing at this point, they are going to die. The thing is, if we are doing compressions, we do run a risk of dislodging that out of the left ventricle. If that is dislodged, that's an open port, and blood is going to flow, and they're going to bleed to death very quickly. So there is a risk of doing compressions, and that's why if the pump is running, no compressions, but if the pump is not running, we need to start compressions immediately. Okay?
Ed,
Yes, any questions?
we start the compressions, we're doing them in the normal rate and depth.
Normal rate, just keep it at 2 inches closer to the 2 than 2.5.
Okay.
That's what one of the recommendations is just make sure you're at about the 2 level. Now, 2 inches on me is one thing, but you got some of the skinnier guys in the room, 2 inches is not going to tolerate. Okay, so I'm going to have to just kind of size it up. I'm going to have to be real cautious with this. Remember, that's the number one problem is dislodgement.
If you're kind of like what we were told by those LVAD group, if the LVAD is not running, when you start compressions, you need to figure out why that LVAD's not running. Right, Chad?
Yes, they have yet to have one seize up and not run.
Cable, unplugged. Something caused it to stop running. You need to figure out what it is.
The only reason it's not been running is when they took it out to do a transplant. That's what they said. They've got a patient that's had it for 17 years now, one of the very first trials, and it's still running. So these things, they don't seize up. There's not that many moving parts in it. There's only one moving part. The bearings are special made bearing for the faster they turn, the cooler they get because of there's some type of a membrane on it. It got real technical. We had to sit through a 4-hour LVAD school the other day, and it was pretty in depth. LVAD patients can be defibrillated, they can be paced, they can be cardioverted. The only thing is I need to make sure that I have good pad placement. Is what we would recommend, and is what Thortec recommends, is that your anterior posterior pad placement for all LVADs. That way you're having electricity straight through, anterior to posterior, instead of an arc going down, which the LVAD sits down here. So you're going to be safer with an anterior posterior. Now, we do have one LVAD in town that's larger, and this may not be feasible if we don't have the manpower to roll them and to get them there. But we sure would be better off having anterior posterior. All patients before they leave have a pacemaker and a defibrillator combo before they leave the hospital, so they should be catching their own VFib and VTAC, hopefully, but they may not be. And to always remember that analgesia is important. Yeah, that didn't come out very well. Pain management can be very beneficial to these patients post or once we start to make the decision in order to defibrillate them or cardiovert them if they're conscious or pace them. We need to make them comfortable. We give you the ability to do that. So let's look at a patient here, 70-year-old female. I'm sorry, 70-kilo female. She was in her 60s. She was found unresponsive in bed by the family, and she does have an LVAD. It appears to be operating correctly. So that's basically what this says. They stated for the last 3 days that they had vomiting denied. The patient was last seen awake at 1300, and that the daughter has, she said she was tired and needed a nap. The family denied any recent pain, bleeding, shortness of breath. Significant history, once again, is the LVAD that was placed in Houston. Family confirmed that no LVAD alarms had been going off, so the LVAD was working properly whenever she went to sleep. Once again, imagine that, a history of congestive failure, which was stage 4, mitral valve prolapse. She has a lengthy cardiac history, once again with the LVAD placement, diabetes, and then she's on multiple medications. Now, one of the biggest things is Coumadin. These patients are kept very thin. They usually keep them at 2+, sometimes at 3+ on the INRs to keep them very thin. So saying that if they were to fall, they were to break something, they were to cut something, they're going to bleed copiously, and we need to be aggressive with that bleeding control. So as we go down, they found the patient supine in bed that was not responding to painful stimuli, snoring respirations with no oral secretions or emesis found. Urinary incontinence was discovered, and there was no obvious signs of bleeding or trauma noted. They did a very, very nice job here documenting that the LVAD drive line was present, that it was read, the LVAD was auscultated, and a constant humming sound was in place. No vital signs. Wow. Well, we don't have a BP. We've talked about that. Pulse is noted to be a little bradycardic. At that point, some snoring respirations and glucose of 33. And so they become, once again, they put an oral airway in her. They are still trying to work it up what's going on. They got oxygen on her, cardiac monitor quickly, which is very good, guys. I can't stress that enough. Please take your cardiac monitors in. You don't ever know what you're going to have, and so the more you're taking it in, the more you're going to be catching stuff early. They get an IV on board, they start a fluid challenge, and then they get the dextrose on board, which goes to 25 grams. They get a 12 lead, which obtained the cause of the patient's unresponsiveness. No ST segment deviation was found on the ECG, so the 12 lead was pretty much remarkable. Then they know that we get VTAC on the monitor. This just goes south on them in a hurry. Once again, they auscultated the pump. Very good job. No LVAD alarms were sounding. They got the once again the glucose on board, but then they have VTAC at 190, and they defibrillate because the patient is unresponsive. Okay, this is where you got to kind of weigh it. Do we cardiovert? Do we defibrillate? I mean, if they're not breathing, and now at this point she's apneic, I would probably say I would defibrillate instead of, now if she's still breathing on her own, that may you have to be with a little cardioversion. Do you have anything to add on that? It's kind of a hard line. Judgment call, guys. If they're breathing, you might be always safer with synchronizing it, just in case. I mean, not really any harm or foul there. They made the decision to defibrillate here, and they got her converted. They went ahead with the amiodarone. so we can keep her out of VTAC. Passive oxygenation, once again, she's apneic at this point. They have to make the decision to go ahead and intubate her. And then they're running into a problem with pressure. Well, we don't have any pressure. She's starting to kind of come around. She's starting to bite the tube. So what are you going to do? The only safe drug here is ketamine, because you're going to drive pressure. Yes, I'm going to ask a little bit more out of the heart, but it's the only safe thing to make them comfortable at this point. So they went ahead and chose to use the ketamine. Got a secondary IV for safety purposes. And so guys, this is where the history is paramount. You got to have a great history from the family. You got to know, was there problems with the pump? Have you been having trouble with the pump? Has the pump been running? Has she been tired more than lately and more than normal? Has she been having normal activity? What's been going on? And this is one of these things that you've got to be a great historian. You've got to go dig. These people, they live with their family. The family takes care of them full time. They change the batteries out. They put them when they put them in bed at night. They put them to the power module. They know these people. It's like a sick chronic kid. That mom and daddy know that kid like the back of their hand. Same way with our family here. Use your family to your advantage. Call the LVAD coordinator if you need to. Take a trained caregiver with you to the hospital. They're going to be the only ones that are going to know the ins and outs of how to change this out. And always, always make sure to grab the go bag. The go bag contains spare batteries, an extra controller, a spare controller, we need to have that, and other vital components that they may need. Chest pains, acquired, they can still have chest pain. Their heart's still beating. They have electrical pathways. They can still have MIs. We want to make sure that we get a 12 lead. They can still have STEMIs. Oxygen fluid, if indicated, if they've been a little dry. That's the number one cause of chest pain is low perfusion. So we may have to tank them up with a 500 cc bolus or a 250 cc bolus. What did we decide there? What did you decide?
It ranges between 250.
Okay, 250 to 500 NS bolus is what you get to do. And then take care of their pain. So if they're alert and oriented and they're having crushing pain, you can give them fentanyl safely. Fentanyl has no myocardial effect and no blood pressure effect. Remember, we want to do anything to affect flow. I need to make sure my flow is intact at all times. The don'ts. They don't need aspirin. They don't need their Plavix. They don't need any more anticoagulants. Their INR is already greater than 2. Do not administer nitro, morphine, or any other blood pressure lowering drugs. These people can't afford flow problems. So you've got to keep that perfusion. You got to keep the preload up. So I'm going to give more fluid to get the preload up. Remember, my pump can pump up to 10 liters per minute. That's over twice of what the heart normally does. Now, yes, I understand we're flowing here. We're not pumping. But at the same time, they can't have anything affect the preload. Patient number 2, male in his 40s, chief complaint. He's about 6 months post-op from his LVAD. He has a crushing chest pain. He's calling it a 10 on 10. He called EMS. It woke him up from a nap. Started having the chest pain. Was advised that the pain was like it was before with his last cardiac event when he had stents. That should be that big red flag. Ding, 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 ding. We got problems. Stated that it increases when he gets up and walks around. So that tells you that the demand is there. When he needs more demand, that's when he hurts more. Patient does have some nausea with chest discomfort. Wife states that it woke him up from the nap about 1:30 in the afternoon. Once again, congestive heart failure. He's got a couple of MIs. He got some stents 3 years ago. He's got an LVAD. Denies any allergies. He's on aspirin and Coumadin at home. Sorry, got a hole in my lip. As we go to assess him, once again, they found sitting in a chair. They've done a very, very nice job. Notice that he's slightly gray in color. Guys, this is where I'm going to have to go. Ma'am, does he normally look this color? Does he normally look this bad? I've got to have her because I don't know him. With him only being six months post-op, he still may be the gray color. He still may not be perfusing great. So I need to know, is this his normal for him? Because to me, he might look bad, but she says, oh no, he looks really good today. And so that's what you're going to hear with these patients. But I wouldn't know that going into it. And so I've got to use my family. Once again, pulses are absent. Wow. But they did a very nice job documenting that his humming noise in the upper left abdomen. That he complains of heaviness once again on the chest. They do a very nice job documenting everything here and covering their bases. Once again, the initial was no blood pressure. They were, once again, didn't have a pulse. They got their heart monitor on, figured out it's about 84. It looked good. Showing a sinus rhythm on the cardiac monitor, no obvious ectopy noted. 12 lead was done at this time. Lung sounds can be heard, once again, in the LVAD in the lower. So they did a very, very nice job documenting here. Cardiac monitor, 12 lead, once again, showing elevation in V1, V2, and V3. That's somewhat normal, or somewhat to be expected with these patients. Remember that V4, V5, and V6 is looking right at the left ventricle. There's no electrical pathway going through the left ventricle. So typically you're not going to see a lot of activity. Those P waves and the QRS complexes are going to be from the right side that you're seeing there from beating across. So you're not always going to get a great picture with that V4, V5, and V6. They got an IV going. Once again, you did see the elevation pretty marked in V2 and V3. Definitely something to be concerned about, so we need to be very aggressive with this fella. He's already got a sick left side. We don't want to create a sick right side. Once again, he was nauseated. They gave him a little fentanyl. They got his pain under control somewhat, as much as they could. These patients, they got to the emergency room. Patient Stacy feels slightly better, was more relaxed. Well, thank goodness for the fentanyl. Once again, they got entitled CO2s. They still got the pulses and taken to the ER on arrival. Now, guys, these patients can go to the cath lab. If they're having an MI, they're going to take it to the cath lab. They're going to run a guide wire up in there, and they're going to figure out what's going on. They're going to do a dye study just like before. It has no effect on the coronaries. It is only the flow or the actual contractions that is taken over from that left side. So they can still have, once again, they did another 12 lead. They did a very good job. And then they gave report over. And as you can see, so the battery packs, once again, they did a very nice job here. The battery packs were left with fresh charge. Once again, guys, if we're going to be going to the hospital, those batteries are good for 10 to 12 hours. I would take the power module with you, if at all possible, if the patient's fairly stable and you have time to package it. It definitely grabs fresh batteries. That gives you roughly 20 to 24 hours worth of battery without the power module. But we're going to need that power module at some point. But I do need to take the go bag, which will have the 2 batteries and the controller in it with the pack. Difficulty breathing, shortness of breath call. According to our protocol we have, guys, once again, they don't need Lasix. You know, typically they may be on some Lasix at home, but we're not going to be giving them any, thank goodness. We don't even carry it anymore. These folks need preload. They do not need CPAP. It's an absolute no-no. Remember, the higher pressures that I'm creating in the chest is going to put more pressure on the inferior superior vena cava, which is going to cut my preload down, which is going to cause problems because I'm not going to have my afterload on the left side. So I've got to be very diligent with how I do this, but these patients can be intubated if needed. They can have one dual nab if they are needed. If they are in a shark fin, then I can, and they're bronchoconstricting, they can still get sick with pneumonia, but I only need to give them one dual nab. Remember, the inotropium built in to our dual nab is going to ask a lot more out of the heart. We don't have a lot out of the heart to give right now, so we have to be, we're kind of robbing Peter and paying Paul. We have to be very careful with how much we're giving right now. Stroke, this is one of the number one complications post-surgery, along with infection of the driveline, is the CVA, hemorrhagic and ischemic. Once again, at this pump, if they get a little thick in their blood, they start to make boogers, and they start to throw those boogers, then I could run into a problem with having clots in my brain. These patients, if TPA is available, avoid this unless specific for that patient. They're going to make that decision at the hospital. We do need to notify them, hey, I've got a code stroke. They're going to get them in. These patients can have clot retrieval. We talked to Dr. Alderazi. These patients can have clot retrieval. So we can get them here, and this would probably be the better of the treatments, in my opinion, is to get them where they can do the most, because there's not a lot of options anticoagulation-wise with these people because they're already anticoagulated. They've got to be very judicious with how they take care of this. A lot of supportive care for these patients, expedite transport, just like we do with all of our other CVAs, and get them to the hospital quickly. Pain management, we did have one of our LVADs tripped and fell, broke his hip. It's very painful. We do have pain management for these people. Fentanyl, nasal, IV can be given. You also have, if it's a horrible bad situation, you can move to ketamine for these folks. Just remember, my ketamine is going to ask a little bit more out of my heart, so I need to be very judicious with how I give my ketamine here. It's going to be at the 0.5 milligrams per key, but once again, I would sure try to stay on the fentanyl side before I would ask a lot out of my heart on the ketamine side with these people. Just one of these things we've got to think about and think about how our drugs affect our system. Once again, we have to avoid morphine here because of the hypotension. We have to avoid NSAIDs here because they're already platelet deaggregated and they already have anticoagulation on board. Other pharmacal considerations, guys, for sedation. You have your Ativan, you have your ketamine. These are better choices due to the mental effects on blood pressure than Valium and Versed. Now, Ativan, if they are seizing, pretty much all odds are off. You can't let them seize, so we've got to do something to them, and it's kind of that, which way do I go with it? I would probably go with the Ativan route. Now, I understand that Versed nasally, that's what we want for seizures because it expedites getting that done, but what is Versed going to do to pressure? It's going to drop our pressure exponentially, and it may cut the flow down where they don't have it. So I'm going to have to be judicious here, get an IV, and I need to give Ativan here in order to stop the seizure. Once again, our cardiac drugs we have to be very, very careful with. Our amiodarone, our lidocaine, our beta blockers, calcium channel blockers, anything that they may be on, or you may be at a doctor's office, they may be saying, hey, we need to give some catapress or whatever they're going to be giving. We've got to be very careful with what we're giving these people because of flow. We've got to keep our preload up. Mag sulfate needs to be avoided with these patients. Remember, our bad respiratories can have mag. Typically, that's going to be on the asthma side. At these people's age, typically it's a chronic issue, so chronic bronchitis instead of asthma, so they're not going to be able to have the mag at all. Do you want to talk? You want to have any comments there? You want to talk about? Okay. Remember the human factor and should not be ignored, okay? Allow these patients to get in a position of comfort. Guys, it may be that if they sit this way, it feels better than if they sit this way. You're going to have to just kind of make them comfortable. They've got a device that's inside their chest, underneath their chest cavity. They've got to be able to get comfortable. Most of them are not going to lay flat. They're not going to do well laying flat. They may sleep up a little bit. You may have to keep them propped up. Be very careful with the cables and controllers. Avoid getting them wet and avoid scissors being around them. They are going to be protective. They are going to be overly protective of their equipment. Don't take it as they're being ugly to you. They just know that's their lifeline, and they may be grabbing hold of it and protecting it while we're moving to the cot. Accept the caregiver's help. I can't stress this enough. Listen to their advice. Now, if they're telling you to give, he's got to have 10 of morphine, okay, I know that's bad. But for the most part, if they're saying we need to do it this way, we need to connect it, listen to them. That's what they've done is they've lived with this patient and they understand the ins and outs of it. LVAD patients, they may tire easily, so we need to prevent a lot of exertion. So if they're fairly fresh post-op, I need to probably baby them a little bit more. I may need to lift them. It may hurt for you to lift them. It may hurt when you pull up their shoulders. They may need to stand up, but I may need to give them a lot of assistance. Any questions before the quiz? Any questions about LVADs? Okay.
I'll just make a few comments. I think that was a great lecture, and you're right. We're going to start seeing more and more of these. It's great that Lubbock's becoming a place that we can put these in. so people don't have to travel so far. I think the take-home message, and I'll preface this by saying I've never seen a patient with an LVAD. Who in here has seen a patient with an LVAD? So just a few, right? So it's something new. I bet a year from now, I bet that's very different. Probably everybody has run on one of these patients. I think the biggest take home is, no drugs like we talked about the nitro, kind of those vasoactive drugs, try to avoid those. And then any drugs that's going to further thin the blood, like we talked about the aspirin, Plavix, things of that nature. I think another big key is if in the cardiac arrest situation, remember we essentially do everything just like we do for anybody else except for compressions. We probably almost never will do compressions because we talked about the pump should always run. If it's not running, really our big goal should be, okay, why is it not running? Plug it back in or do whatever, and 99.999% of the time it should still be running, right? Even if they're in cardiac arrest. So it should be very rare that we ever have to actually do chest compressions. That's about all I got on it.
And then if they're seizing,
Get them treat, yeah. Anything else, treat.
Yes.
I mean,
If it's
arrhythmias,
life-threat.
treat, shock them. I do wonder if it can do anything to the device or the controller and defibrillation.
They say that it won't hurt it.
Yeah, I mean,
You just don't want it to
theoretically
be right over it.
Right.
That's why pad placement is so crucial.
But I think it is important if we do shock, and I'm sure they test it and have it shielded somehow, but after we shock, probably the first thing we should do is that pump still running?
Yeah. Call the LVAD coordinator.
Yeah. Cool.
No, we learned a lot about the LVAD, that little class that Chad, Kim, and I went through, and just touched some of the things that stuck in my head. That's real important. Like they told us, an LVAD is very dependent on preload. The pump is very dependent on preload. They tell most LVAD patients when they get it put in that they need to have at least 1 liter of water a day, if not 2 liters of water a day. Because if they get dry, they go downhill because that preload's not there to help that pump. There's nothing there to pump. So sometimes when you find them kind of unresponsive or in any way, shape, form, or fashion, they may just need, like Chad said, 250, 500 cc's of fluid. Something to give them some preload for them to have to pump. Okay. They even talked about how that pump, just to let you know how much it can turn. If the heart gets too dry, preload wise, the pump can actually suck the heart into the ventricle, to the left ventricle. So it can bow the heart. Remember them talking about that? And vice versa, if you have too much preload, it can do the opposite effect. And I mean,
the right side.
it's so interesting. And after watching that class with them, I mean, to me, in LVAD patients, they're not scary like I thought they would be. If they give you a hard time, unplug them. Just kidding.
I think another couple things, and we talked about it, try to get the gear that the patient has. Whatever we plug into the wall, ideally if we have time, get that, because, and I don't know how readily available this, obviously I assume UMC is going to have some backups of these, but it may take a little bit to get that, and certainly if you're working out in the region somewhere and you're going to go to XYZ hospital first, they're going to freak out when the patient shows up. And also I think it's good to maybe let the patient and the families know that I've had training on this, because like I say, they're going to be very cautious about it. And also I think if we get called to a medical clinic, one of these patients walk in to, or at a family doctor or an urgent care facility, they're going to be freaked out, the nurse practitioner, particularly the doctor there, because they're not used to this. So I think it's also worth, we've had specialized training, I'm comfortable with these. You also look like a superstar.
Yeah. Just don't give anything that affects flow when you're going. Okay. All right. An LVAD is usually implanted in the patient